Live.
All right. Okay. I'm hoping that the question in the chat group was answered now that you can all hear and see me. Welcome to the digital conference today. Uh, Ava Carr is back with us, monitoring and overseeing the proceedings on behalf of Diagnexia. And it's my pleasure to be with you for the next hour or less. So the way this conference works, if you the first time around, is I show cases that I've encountered over the years with you. I show you the digital version of them. These are slides, H&E slides that have been scanned, and I will provide you the history and then show you the morphology, and then uh, anticipate discussion regarding differential diagnoses, investigations, and so on. So that's the way it works. There's a chat group, so you can put in your questions or your answers in the chat group, and we will go from there. So the first case I have for you today is a young adult, and this is a tumor that was resected from his thoracic body. So it's a thoracic spine, and this is a T12 body resection. And this is a section of that tumor from the T12 body, and I'll take you through that momentarily. Just on low power, you can appreciate that there's some normal bone here on the top left-hand corner of this, and I'll show it to you. Marrow elements and trabecular bone, and you can see the tumor here in the bottom right, which is invading or breaking out into the soft tissue, surrounding soft tissue here as well. So clearly involving soft tissue. And I will show you the tumor close up. I'm trying to find a nice section that's not too thick. Okay, I think this is probably as best as it gets. I hope you can see these osteoclast-like giant cells and these spindle to epithelioid cells in the background, the stromal cells. These represent the embolic material. These spaces are the embolic material. Let me show you more of that. That was injected by the radiologist to prevent any bleeding and reduce the size of the tumor during surgery. So, or reduce the vascularity during surgery. Back to the tumor, just to reiterate what we've just said. These osteoclast-like giant cells, quite vascular, richly vascular. You can see these staghorn type vasculature, and then the tumor cells or the stromal cells being spindled to epithelioid in the background that you can see. And like I said, just back on low power, you can see this invading and breaking out into the soft tissue. So these are all islands of tumor breaking out into soft tissue. Yeah, there's one of those embolic material right in a vessel. You can see that's just an artifact if you haven't seen that before, just to share with you. These islands look pretty much clearer with morphology. Osteoclast-like giant cells, these spindle cells, and some of them looking epithelioid as well. And like I said, the stroma is quite vascular as well. So I'm just going to go into the chat to determine what your... Okay, so we've got some yes, hi Isabel. I hope Rashmi and Madhu are back in. Guion from Ethiopia. Isabel, giant cell tumor. That's a good start. They are unusual in the spine, but they do occur in the spine. They can. I've seen a few of them. Jan has suggested an ABC versus a giant cell tumor of bone versus a keratin positive giant cell tumor. So we have three differential diagnoses there. I'm not. You're referring to the xanthogranulomatous keratin positive giant cell tumor. Okay, I got you. Those usually occur in soft tissue, as far as I'm aware. So this is intraosseous breaking out into bone. Uh, so we'll keep that in abeyance. So I also have Madhu here. Will it be classified as pigmented synovial tumor? I'm assuming you mean tenosynovial giant cell tumors. Those can have pigment. We can have hemosiderin and lipofuscin pigment. So those would be yes, that would be in the differential diagnosis as well. Those can occur. Remember, you get the joints between the body, the facet joints, and the synovium that lines these joints, and those can give rise to tenosynovial giant cell tumors. Quite correct. So that would come into that differential as well. Knee, okay, yes, yeah, tenosynovial giant cell tumors typically in knee, hands and feet in the joints. So that would be a major differential diagnosis. Let's just go back and look at this. This one doesn't have much of the pigment, and the stromal cells are a little more spindle than usual, but there are some epithelioid cells as well. And the pigment is not a feature that we see in the typical tenosynovial giant cell tumors. But clearly, yes, that would be in the differential diagnosis as well. Tenosynovial giant cell tumor. And so the giant cell tumor of bone, typically, again, just to come back to the morphology, these are predominantly osteoclast-like giant cells, and giant cell tumor of the bone typically has lots and lots of nuclei, many, many, many more nuclei. The stromal cells are very much epithelioid, and it has been said that the nuclei of the epithelioid cells resemble the nuclei of the giant cells. And again, giant cell tumor bone these days we know carries the mutation involving H3, that histone 3, H3F3A, and there's a protein that's expressed which we have an antibody for, which is the H3G34W, which is useful for giant cell tumors of bone, and we have that marker. So if you do have that marker, it's useful, and if you apply it to here, would be negative. So giant cell tumor of bone is a good thought. G34W being negative, ruling out the mutation of H3F3A. Giant cell tumor bone, solid ABC. Yeah, I like that. There's nuclei in giant cells are too many. Yeah, that's in the giant cell tumor of bone. Here, these not that many, and these look much more like osteoclast-like giant cells. Some of them do have greater number of nuclei, but in giant cell tumor bone, it's the other way around. You get more giant cells with numerous nuclei and fewer osteoclast-like giant cells. This seems to be more dominated by osteoclast-like giant cells. I think the tenosynovial giant cell tumor is a good differential diagnosis. Giant cell tumor of bone is a good differential diagnosis. But Jan has mentioned the solid ABC. This lacks the aneurysmal changes, and remember I was showing you these sort of microcystic aneurysmal changes, if you will. I was showing you many of these materials that have been the embolic material that they use just to not confuse with aneurysmal bone cyst changes. And Jan, you're correct. You're quite correct. There's some here which have these so-called almost microcystic rather than macrocystic. So you don't see it grossly, and you don't see it on the radiology. And the best way to confirm this would be with a USP6. That's the ubiquitin specific protein 6, which is a gene that's rearranged in these tumors in the ABC, aneurysmal bone cysts, and USP6 was rearranged in this. And so with the radiology and the morphology, this would fit with the solid variant of an ABC. These are very rare. They're extremely rare, and I believe in single digits rareness. I cannot remember the figure, but it's unusually rare. But keep it in mind and keep it in your differential diagnosis. And I think the ones that were shared in the chat, pretty decent. Dorothy, osteosarcoma. Well, that's going to depend again on both radiology, showing you a destructive tumor that's breaking out into soft tissue with mineralization. This does have some microscopic bone scattered about, islands of bone, but the radiology is going to play a major role in that. And again, they rare in the spine, but they can occur as well. So final would be a solid variant, Madhu, correct. And the ABC, but a solid variant. Can it be osteosarcoma, Ruhani? The answer is twofold. And the first part, which I answered already to Dorothy, is that radiology plays an important role in that respect. And then microscopically, you'd want to see osteoid production in an osteosarcoma in and amongst cytomorphology that looks malignant. These look very bland. They look a little cellular, but they bland. They're no mitotic figures. There's no atypia or varying size and shape of nuclei. So they look very bland. Here you can see a predominance of spindle cells, and even here they look quite bland. There is some bone formation, which I'm looking for whilst I'm talking to you, Ruhani. And there's maybe a little bone here, but even the cells lining these are not. Yeah, there's some bone here as well. They're not ugly, okay? They're not ugly. They're pretty uniform, sort of almost like a metaplastic bone formation in these. And you can get bone formation in ABCs. That's not unusual, but you can get microscopic foci of bone as well. So for osteosarcoma, I'd want a combination of radiology and morphology, and for it to look malignant. And again, I'm not referring to the low-grade versions like the low-grade intramedullary osteosarcoma or the osteosarcoma. I'm talking about the osteosarcomas that look ugly, high-grade, with osteoid production in a background of malignant-looking cells. Remember, they can have a range of morphologies. You know all of this. They can look like giant cells. They can look like cartilage. They can look spindled and even epithelioid. So there is a whole range of that high-grade morphology that you see in osteosarcomas. Not pleomorphic solitary cells are banal. Yeah, they are banal. The woman bone fragment, not sure what that means. Okay, so let's perhaps the other thing perhaps to mention is, well, what are the other tumors that are USP6 rearranged? In using these genes for FISH analysis and for your diagnostic capabilities, you have to know what else it stains. It's like when you use an antibody. You apply an antibody to your tumor, and if it comes back positive, you have to know what the differential is with that positive immunoreactivity. So similarly, USP6 and knowing the other tumors that are rearranged with USP6 are equally important as well. Woven bone, yeah, that's correct. It came up as woman bone fragment. So yeah, I would probably say that the major hint is spindled instead of epithelioid. True, but you can get more epithelioid cells as well in ABCs. There's no real clue. I think it's going through your differential diagnosis and keeping in mind ABCs can be solid, and in this context, thinking about it, and we fortunately have USP6 FISH, and that is positive. Ronnie's responded to the nodular fasciitis. That's the famous one. USP6 is ranged in nodular fasciitis, and that's very useful, particularly these days that you have young patients coming up with these lesions, rapidly growth. And, the old days where we used to call these nodular fasciitis on morphology, pretty much gone, because the surgeons and the oncologists call you back and say, have you done USP6? So, yeah, that's, I often would sign it out and then do a USP6, because not all of them are positive. It's only about 70 or 80% that carry the rearrangement. So that's not always 100%. Bone you pointed out looks like, yes, it does look like woven bone. That's correct. It does look like woven bone. Other tumors that are rearranged, anybody with USP6? Just give you a chance to type in the differentials, because it's useful to know what other tumors are USP6 rearranged. And if there are any residence registrars, these are board type questions. that can be asked as well. Okay, so when you think of nodular fasciitis, so we have the solid variant of ABC and obviously the cystic variant of ABC. Both those are USP6 rearranged, and I think again it's about 70 to 80%. When you think nodular fasciitis, don't forget myositis ossificans. Oh yeah, there we go. There we go. R is just put in myositis ossificans. And those, you really don't need to do USP6. It's the clinical history, the radiology, the X-ray showing the zoning phenomenon and the mineralization in the bone. Those are useful features to help you. That is, Tom has put in a link for us. There, thanks, Tom. He's put in a link. Yeah, there we go. No, we do not mention the. No, you mean the cellular variant of giant cell tumor, giant cell. So let me start that again. Tenosynovial fibroma, right? There's a cellular variant of that, which is positive for USP6. I'm not aware of cellular angiofibroma, but I may be wrong. So you can always fact check to me. R is put in the fibroosseous pseudotumor of the digit, the one we always forget. So those are very rare, and I probably have only seen one or two of those. When I do encounter these lesions in the digits, I always do a USP6 to rule that out. But the fibroma of tendon sheath cellular variant, correct. Myositis ossificans is only a subset of myositis. It's probably about, I think, a third. So I think I don't bother to do a USP6 on a myositis ossificans. But this solid variant of ABC, yes, I want to get a USP6 just to confirm my diagnosis. I think we covered that, Tom. Thank you. There are some rare other things, but I'm not going to worry. Yeah, is cranial fasciitis? I know that the post-operative spindle cell tumor can be USP6 rearranged. The one we see in the bladder, I know, or GYN and bladder. Those have been subset of them have been shown. You may be right that this cranial fact, but just double check that as well. Again, radiology and morphology is pretty useful for those cranial fascia. They grow very rapidly, actually, quite scary. Yes, thank you, Tom. Okay, so cranial fasciitis to that list of USP6 rearranged tumors. I think we pretty much covered most of those as well. Let's move to another tumor, another case. This might be pretty straightforward for you guys, but let's see how you do with it. Yeah, here we go. 22334. So this is a parotid mass, and they call this a biopsy. Okay, that's all tumor. I don't think I've got normal parotid gland here, but this is all tumor. Okay, section's a little thick and did not scan very well. These were older scans from my collection, which I started on this conference, but the more recent scans look better. So here we go. You got to have a lobular configuration. It's quite bloody background, which is a useful feature for this, but nice lobules, and some of the cells look vacuolated. The nuclei fairly round and uniform. And within some of these vacuoles, you can see some pale eosinophilic secretions as well. Okay, so I'm giving you all the nice morphologies to consider. Remember, we're looking at a parotid gland mass. This was submitted as a biopsy, and I'm not so sure why they cut through this. Our surgeons don't like biopsying parotid gland tumors. They typically do an FNA, and they get good guidance with our FNA cytopathology colleagues, who would give a morphological diagnosis and allude to whether it's benign or low grade, or a differential diagnosis, and then surgeons proceed from there. So very, very rarely do they biopsy it. So here we go. Let's see what people are thinking. Mucoepidermoid intermediate grade. Okay, so that's a good start, and I appreciate that, Madhu. Yan acinicell is I always mix this up. Yeah, acina is more for the pancreas, isn't? Yeah. Thank you. You just corrected me there. Okay. Uh, Acidic is salivary and acina is pancreas. Okay, we're building up the mucoepidermoid intermediate grade. Whilst people are giving us their differentials and thinking about this, just to comment on Madhu's intermediate grade. It was a nice paper from the Memorial Sloan Kettering in AJSP about 2-3 years ago. I want to say 23 maybe, or maybe I forget the years. So if you go to AJSP, you punch in mucoepidermoid carcinoma grading Memorial Sloan Kettering AJSP. That's American Journal of Search. That paper will come up, and in that, what they found was that the intermediate grade, as per previous grading classifications, whether it was Armed Forces or WHO, intermediate grade in their series graded with the low grade, behaved as low grade. And so what they did was they lumped the intermediate into the low grade and they proposed a two-grade system. So it's low and high. I like that. I signed out a mucoepidermoid yesterday, and we talked about that paper with the fellow, Natalie, and she was pleased with getting a copy of that paper. So you can look at that paper. Tom, beautiful amphiphilic sensitivity. However, NOR negative, then would go for mucoacina type MEC. Now, that's the reason I was waiting for Madhu's suggestion of mucoepidermoid. Remember, there's a rare variant of mucoepidermoid carcinoma called a mucoacina type of mucoepidermoid carcinoma, and then you can get serous type cells within that. So it's useful. There are about 6 different types of mucoepidermoid carcinoma, and as you go down here, you can see the cytoplasm has that color that Tom has pointed out, the amphiphilic appearance. If you look around, you can see some of them do have zymogenic granules. I'm not sure whether that's going to project too well, wherever you guys are across the Atlantic or the other oceans, but some of them do show some granules. So that would be, and then of course you have these secretions and these vacuoles and pale eosinophilic secretions here as well, which I thought somebody might say secretory carcinoma, but nobody has said secretory carcinoma. That would be another differential as well. And then, of course, mucoepidermoid, you'd want a mucin stain, as well as if you have the privilege and luxury of a mammal 2 fish, that would be help. CRTC is the fusion partner, and mammal 2 would be useful as well. The acidic, I keep making that. I think I might have a. There we go. So the NOR is a protein that's expressed due to the rearrangement of NR4A3, and that protein is known as NOR1, and you can see that it's beautifully positive nuclear staining in this acinic cell carcinoma. So I was glad I scanned this, because the reason I scanned it, because the antibody was very new at that time, and I scanned the slide before returning to the files. Here there may be some parotid acini that are negative, and that's why I'm trying to find that for you, because they're negative in the normal glands, normal acini, but they're positive in the tumor cells. So beautiful NOR1, useful to get, but this does not work in the acina cell pancreatic carcinoma, and nor does it work in the extraskeletal myxoid chondrosarcoma, because that also carries the NR4A3, which fuses with the EWSR1. So NOR is unique to acinic cell carcinoma of the parotid gland, and here is just this beautiful stain that I'm sharing with you. Just looking at some of these islands here, which have some normal acini that are negative. So nice example of acinic cell carcinoma. Yes, it does work, Tom. In my limited experience that I've used, I've probably seen a small handful in the last few years, and it does work. Uh, the other point I was going to talk about, Madhu, I thought it was a thick section, beautiful amphiphilic. Does work. Okay, just catching up with my chat. Uh, points there. The other discussion I was going to have was the secretory carcinoma, and the reason I was talking about that earlier, just to show you these vacuoles and some of them having that eosinophilic secretion. But Tom will tell you that the cytoplasm is wrong for secretory carcinoma, I suppose. But as you know, those stain up with the breast markers, uh, the usual mammoglobin GATA3, uh, and those are negative in actinic cell carcinoma. Now, when secretory carcinoma was first described in 2010, 2011 by the Czech group, Elena Skaklova, they called it a secretory mammalogue, right? Breast mammalogue secretory carcinoma. And now it's got its own name, secretory carcinoma of the salivary gland. But at that time, thereafter, people asked the question, well, how come we never saw those before? And there was a nice paper from Pittsburgh, and this was Raja Sitala. And they looked at all their actinic cell carcinomas and reviewed them. And what they found was about half of them turned out to be secretory carcinomas. So the message is, if you're thinking secretory, rule out actinic. If you're thinking actinic, rule out secretory. And it's easy. It's an easy deal because you have those breast markers that work on the secretory carcinoma. That was the only that's a paper, I think, around 20 mid-teens, guys, modern pathology, I think it was Raja Sitala. So it's just something to keep in mind, historically about these things. So many of these secretory carcinomas were called actinic in the early days. But when you go back to the old armed forces, and you'll see pictures of this as well, and some of them also show those follicle-like, which look like the thyroid, follicle-like they can have, and so on. Okay, enough of that. Let's see if there's anything more in the chat. Indeed, more over nuclear, not uniform. Okay, thank you for that. Jan, it's renamed actinic-like in breast. Oh, really? Oh, okay, I didn't know that. I don't follow the breast literature. Thanks for informing us. Actinic. So the breast people have changed. Okay. You mean the secretory carcinoma is called actinic-like, or the actinic cell carcinoma in the breast? All right. Let's move on. 22585. I got to go back to my list here. 22585. There we go. Okay, this is a retroperitoneal mass, adult. It's a resection of a retroperitoneal tumor. Like I was saying, it's a few years old, but it's still relevant to talk about. And I want to show you this area here. Okay, I'm going to describe it a little to you, not but you can appreciate the myxoid stroma, right? That gray blue. We've talked about this in the past. Be careful of edema. Many people call edema myxoid stroma. I've seen that often. You want to see this nice hue before you call it myxoid matrix. And this is nice. This is myxoid material. Also, just point out the delicate vasculature, thin wall, delicate vasculature here. Okay. Some of these spindle cells, some looking a little stellate, bloody background. And of course, you can see the fat cells there as well. I mean, you a little bit of A-tip here. Okay. Here's more of the same thing here. A little more sclerosing and fibrosis here, but still some myxoid matrix. But you can see these fibrils of collagen in between. I'm just going to go to the chat group to see what people are thinking. I love to hear what you're thinking as we look at the slides, okay? That's why I want to keep in touch with what your thoughts are there. That's the first part I showed you. Let's see what we're thinking. NR483. Oh, this is Jan talking about the 6th edition of the breast due to lack of NR4. All right. Okay, that's a conversation we had. How about this case? Anybody, any thoughts on this case? Myxoid liposarcoma, absolutely. Yeah. Any other differentials? Low-grade myxofibrosarcoma, yes. All these are great differentials. This is what you should be thinking about when you encounter such a tumor. Remember, this is retroperitoneum. We'll come back and discuss each of those. So we've had myxoid liposarcoma, we've had myxofibrosarcoma. Okay. And then I'm going to show you some of the this whole thing has a similar morphology. Yeah, there's a little more sclerosis here. And there's more fat here. Okay. Anybody wants to do any investigations? What investigations? We've got, let's see, when I last looked, it was 2. Oh, okay, this is a third. Wonderful. Low-grade fibromyxoid sarcoma. Yep, that would be all except MUC4 always, correct? And what about the myxoid liposarcoma? Any thoughts there? What would you want to do? We've got a couple of myxoid liposarcomas. I like that. DDIT, yes, Ruani. And DDIT, you can do an antibody. There was a nice paper from Brigham and Women with the DDIT showing pretty decent correlation with morphology and fish. It was written by, you may or may not know this, Esther Baranov, our own colleague. Given heterogeneity, of course, we mentioned ALT with co-amplification of DDIT. So Tom, of course, has jumped the gun right into the pit of it, which we'll come back and discuss. And then, of course, given the location of retroperitoneum, Rohan, I think that Rohan, MDM2 and DDIT, I like all of those. So Jan said myxoid well-diff liposarcoma versus D-diff, given the location. Correct. So these are all good answers, and these are all good differential diagnoses for the discussion point. So firstly, let's look at the myxoid liposarcoma. And yes, of course, you'd want to do a DDIT. DDIT is the gene that's rearranged with either FUS or EWSR1 for myxoid liposarcoma. And DDIT is common to both. So that, as you know, is rearranged classically in myxoid liposarcoma. Myxoid liposarcoma, the terminologies have changed. We don't use the term myxoid liposarcoma and round cell liposarcoma. It's all myxoid, low grade or high grade, based on nuclear pleomorphism and round cells. So having said that, the other point would be myxoid liposarcoma, just for this conversation, does not occur in the abdomen or retroperitoneum. When you see a myxoid liposarcoma in the retroperitoneum, always ask the question, is this metastatic? Has this patient had a tumor in the thigh in recent past, and has this metastasized to the retroperitoneum? So that's the second point. Now, having said that, I know you look at the literature, there were 5 cases from Japan who presented 5 cases of myxoid liposarcoma, bona fide, without metastasis. But for our conversation, you always want to rule out metastasis when you see myxoid liposarcoma. That's the first point. The second point is, if you did do a DDIT here, which would be correct in doing it, it is not rearranged, it is amplified. Amplified DDIT, a gene that's amplified, is not a feature of the rearrangement of myxoid round cell liposarcoma. Okay, and that begs the question, where and how does this fit into what we're talking about? And I think Rohan has hit it on the head by saying he or she wants an MDM2, and MDM2 is amplified, as you know, in the liposarcomas in the retroperitoneum, both the well-differentiated liposarcoma and the dedifferentiated liposarcomas. So MDM2 is amplified in this case, and DDIT is also amplified but not rearranged. So what this is in truth, this is a dedifferentiated retroperitoneal liposarcoma with myxoid liposarcoma-like changes. And that's the reason for showing it, is that you can get myxoid liposarcoma-like changes, particularly in the retroperitoneal ones. And if you get a needle core biopsy, you'd have to do an MDM2 as well. And DDIF would be amplified, not rearranged. So that's helpful. There was a series of this from the group in Albuquerque, New Mexico. Again, don't ask me for dates, guys. But modern pathology, if you Googled retroperitoneal DDIF liposarcoma with myxoid liposarcoma-like changes, that will come up. And there was a subsequent follow-up to that paper from another group as well. So these are all important, obviously, with needle core biopsies, and so that would be useful in that as well. And then I'm just smiling at Tom's comment. He's just fresh back from the the Montreal Grand Prix. Tom is still racing away. Okay, all right, all good fun. Did I answer all the questions? Let's see. Yeah, Tom's given that perfectly. The low-grade myxofibrosarcoma, that's important as well, because if you're looking at something that looks like a low-grade myxofibrosarcoma in the retroperitoneum, you will have to do MDM2 as well, because dedifferentiated liposarcoma can look like myxofibrosarcoma. So being aware of these various or heterogeneous morphologies would help you then do an MDM2, either antibody or FISH, to show that this is in fact a dedifferentiated liposarcoma. So that's important as well. Low-grade fibromyxoids, yes, they can occur in the retroperitoneum. They're rare, but they can. MUC4 always, yes, Jan. And then if you have FUS, that's useful as well. And then I think we answered everybody's questions. Samuel, morphology looks bland. How do we arrive at malignant features? Well, the amplification of the MDM2 helps you there, Samuel. That puts it right plumb into the category of a liposarcoma, and in this context, dedifferentiated liposarcoma. You would then grade it based on the FNLCC criteria, mitosis, cellularity, and necrosis, and grade your DDIF accordingly. Okay. But that's another story. How do you that's also been an interesting discussion that's emerged or re-emerged, the well-differentiated liposarcoma with spindle cells versus the low-grade dedifferentiated liposarcomas, and that's been written in the last few years. I mean, this started 10 years ago, or maybe longer, 10, 15 years ago, by Harry Evans, saying that the well-differentiated liposarcoma with spindle cells, mitosis less than 5 per 10 high power field, behave the same as well-differentiated liposarcoma, either sclerosing or inflammatory or lipoma-like. And that's where that conversation comes from. And then more recently, other authors from New Hampshire and Los Angeles have picked up that, and so that does make. I think it's based on grading these dedifferentiated areas using FNLCC criteria. That's the best way to go. Madhu, how do they fare prognostically? I think, like all DDIF, if it's a low grade, then the prognosis is slightly better. But the high grade DDIFs, 40% of them metastasize. So once there's DDIF, then the potential for metastasis is always there. The WellDIF, no. WellDIF will just recur, does not metastasize. So it's all to do with metastatic potential. And then, of course, in these, unusual morphologies, it's going to be based on how you grade these with the FNLCC. Okay, grading system. All right. Okay, yeah, there's another point. Yes, that myxoid WellDIF is also proposed instead of always DDIF. One of them I do not even threshold. Yeah, it's all to do with my. In fact, there was a nice paper, I think, in. Oh dear. I think it was Virkov Archives. from a group in China, and I cannot remember which city that was from, who discussed this with the huge numbers, 200-300 of these, and discussed the same principles of mitoses and DDIF versus WellDIF. So it's an ongoing conversation until WHO presides over it. We'll just hold on. Okay, we have time, I think. What's it? 1:44 on my side. How about this one? This is an interesting one. 7954. Sorry, guys, I gotta go back to my screen now. Here we go. 7954. There we go. So this is a nodule. This is a neck mass. The neck mass, 43 male neck mass. There's some artifacts there, so I'm just going to go for this nodule here. But you can see that this was shelled out by the surgeon with a little bit of skeletal muscle. So it's pretty deep. Okay, it's deep. And I'm just going to show you the skeletal muscle around there. Yeah, that's just a staining artifact. But if we go down on higher power, you notice there's this sort of almost sclerosing, fibrosing area in the periphery, but in the central area, it's mainly spindled, short fascicles, spindle cells. Again, your favorite myxoid stroma, a little bit of myxoid stroma. Okay, ovoid-looking cells, some spindle cells. These look more degenerate, guys. So don't get worried about a tip here. They look more degenerate. This is the classic picture here I want to show you. It's a classic picture here. Myxoid, short fascicles, few lymphocytes scattered about. Yeah, that's no, actually that's not degenerate. That's just the nuclei of muscle cells. As this thing grew in the muscle, the nuclei, the sarcolemmal nuclei, have this hypochromatic appearance. So just ignore that. Just ignore that. You see that always. All of these are just those dark-looking cells. But as you look at the periphery, you can see it's looking more sclerotic. It's starting to, yeah, this hyalinized and sclerotic. Yeah, you can see this point here. If you've never seen this phenomenon before, as tumor invades and involves skeletal muscle, they undergo atrophy, and these nuclei start to proliferate. Be careful of that and not to call it tumor itself, particularly if you're looking at margin status like in the oral cavity, tongue, mucosa, and as it invades, you get this sort of hypochromatic, bizarre-looking nuclei. But back to the tumor. Short fascicles, a little bit of blood outside there, some mononuclear cells, and then the periphery is more sclerosing. Now, this was a nodule in this 43-year-old man, and his history was that he noticed it a few months ago, but he's been following it up, and in the last few months it was decreasing in size. That was his history. Okay, let's see where we. Oh, I'm got to go back a little. I missed a few comments here, guys. Sorry. Jan has given us a reference. WellDIF, DDIF, prominent myxoid, and as there you go, histopath. I don't know if that has the myxoid liposarcoma-like picture, but you can check it out. I'm not sure because lipomas and well-differentiated liposarcomas can have myxoid stroma, not to confuse with myxoid liposarcoma because they don't have that vascularity. So just check that point up there. Okay, so we've got Madhu here, synovial sarcoma, and Madhu, these are atrophic skeletal. Yeah, that's what they are, atrophic skeletal muscle. Any other thoughts on this this lesion? It's very small. You can see that's fairly well circumscribed. Let's go to one or two of these other nodules. It's the same thing, just sectioned across. There's a spindled myxoid stroma, some mononuclear cells. Any other thoughts? Like I said, he noticed it a few months ago, but it's been decreasing in size in the last month or two. So it's sort of, and you can see why it's decreasing because of the sclerosis in the periphery. There's fibrosis here. The central sort of more proliferative areas not yet that sclerotic, but you can see that here it's starting to undergo the sclerosis. See that? Let's see if that gives you a sclerosing rhabdomyosarcoma. Okay, so the markers, and I typically do a panel of markers that covers synovial sarcoma like keratin and EMA. Those are both negative in this. I don't necessarily do a TLE1 or launch into fish analysis, but I use those as screening markers. Neurothekioma, I think you're referring to the cellular neurothekioma. Those tend to be more superficial. This is quite deep. And then there's sclerosing rhabdomyosarcoma. And again, for that, I'd want to see Desmond as well as myogenin and MyoD1 for me to go into the rhabdomyosarcoma route. One of the things I've learned is that if you're seeing spindle cells, round cells, and if they show any muscle immunoreactivity, either actin or Desmond, obviously you're going to take it forward and ask yourself, well, is this a spindle cell rhabdomyosarcoma? And do a Desmond and a MyoD1. Always take that forward. With round cells, alveolar rhabdomyosarcoma, etc. And then you're going to ask yourself, well, is it smooth muscle? And for smooth muscle, I not only do a Desmond, I like to do an HCal Desmond, which is helpful for smooth muscle. And I want to see smooth muscle fascicles, long sweeping fascicle, cigar-shaped nuclei. And if it's higher grade, I want to see areas that show well-differentiated leiomyosarcoma. And then also with muscle, you also have to think about all the other tumors that can have muscle, like inflammatory myofibroblastic tumor that can be actin positive, can have a little bit of Desmond. So, if the inflammation is there, think about things like IMT and do the ALK. Also PEComa, don't forget PEC or PEComa, perivascular epithelioid oma. You'll have to think of the melanocytic markers and sometimes even TFE3 as well, subsets. So when you see muscle, always expand your thinking into what else could it be. Is it smooth muscle? Is it skeletal muscle? Is it myofibroblastic? Or is it PEComa as well? So in there's several other things like myofibroblastoma, etc. But when you do have muscle immunoreactivity, always expand your thinking and follow that according. The neurothekioma was a term that used to be used in the old days and was some confusion with nerve sheath tumors. But in the last decade or so, I think it's sort of kept its name as a cellular neurothekioma. They tend to be superficial, hanging out in the skin, very close to the epidermis, and they're negative for most markers. There were some papers showing things like CD10 and CD56, but I don't use that. The NKI-C3, if you have that, it's so-called putative melanocytic markers. If you have that, that's useful. But exclusion of other things, I think, are important for the cellular neurothekioma. Any other thoughts? So I did a USP6 because I thought this was a nodular fasciitis. It's deep. I've seen some of them being deep and have diagnosed some of them in the past. And the central parts look decent for that with the short fascicles, some of them looking cellular. There were a few osteoclast-like giant cells, which I just couldn't find as I was talking, trying to find them for you. I couldn't find them. But there's also sclerosis in the periphery as well. And the USP6 came back as negative. Now, there's a paper again 2-3 years ago, I think it was Modern Pathology, that spoke to the signals that you would see in USP6 rearranged nodular fasciitis. And what that said is the older the lesions, as they get older, so meaning 3 months and more, you see fewer and fewer signals. And so when this came back as negative, I wasn't too worried about that because I thought that this was fitting what that paper was talking about. And I still called it on morphology. There was some actin immunoreactivity. And so I called it on morphology nodular fasciitis. I haven't heard anything about it since then. And so, I'm assuming the patient is well. Remember, if you call something nodular fasciitis and it comes back, then you have to go back and look at it again. Although more recently they've been talking about some that have been aggressive because these are now regarded as neoplasms. So it's been an area that's been changing and shifting in recent times. Any questions on that? Anybody? Feathery look? Yeah, not quite, but with the erythrocytes, yeah, you know, I hear what you're saying, but all of my other immunos were negative, and that was my best morphological uh, interpretation, along with the sclerosis and along with the lack of USB signals, was the only way I could interpret that. But feathery look, yeah, that's mainly in the younger lesions. Okay, uh, part of my point is that in the younger lesions you see more myxoid stroma, and the myofibroblasts look as if they in a culture plate, and that's how they have that sort of feathered look, and culture like myofibroblasts. This is more sclerotic. This is more older. Cells are more mature. There's a little bit of myxoid stroma. So yeah, uh, seems cells should be more epithelioid for sclerosing epithelioid. Yeah, and MUC4 was negative, Rohan. MUC4 was negative. What about myxoid fibrous histiocytoma? I think you mean the myxoid AFH, angiomatoid variant of myxoid. I did not do any of the fish for that, which would be EWSR1 and ATF. I wasn't that impressed with the lymphoid tissue here. Uh, on low power, it looks as if it has, but there's no lymphoid cuff here. I think these are just the myofibroblasts, and these are just the skeletal muscle. Okay, so all right, something for you to chew on, something to think about. We have a minute or two. Myxoid AFH. Yeah, correct, myxoid AFH. Reparative. Well, that's always true, Mother. You could argue that as well. Uh, this seems to have some sort of a zoning process as well, with the peripheries being so uniformly sclerotic. It's always going to bring discussion, which is what I entertain, which is why I put this case in, for you to think about it and challenge me. I like that. I enjoy defending these things. But Ava will tell us that the next meeting is going to be in June 17, same time. We'll do a meeting June 17, and at that time I should be able to give you dates for the latter half of the year. And remember, if any friends, colleagues want to join up, you can send the email that you get to register to them, or they can email Ava and get onto the list. Okay? So thank you again for spending this time, and always fun spending this time with you guys. Have a great month, and see you next month. Thank you.
Thank you. Have a great rest of your day.
You
Thanks
too.
everyone for attending.
Thank you, Ava.
Bye. Thank you.
Bye. Thank you.